The importance of timely introduction of vancomycin therapy against methicillin-resistant Staphylococcus aureus bacteremia and severity of MRSA bacteremia teaching hospital Anuradhapura, Sri Lanka. Worldwide, an estimated 2 billion healthy people carry Staphylococcus aureus, and of these, up to 53 million are thought to carry MRSA. Staphylococcus aureus is a feared pathogen because it causes severe infection and spread by metastasis foci. Cells commonly colonize the nose stream, skin, perineum, respiratory tract, open wounds, and pneumothorax, which serves potential site for the infection. Over the past decades, the incidence of Staph aureus bacteremia in hospitals and community has significantly increased. Over the past 3 decades, numerous outbreaks of MRSA bacteremia have been reported in hospitals in South Asia, including Sri Lanka. The therapeutic options are limited to use of glycopeptide mainly and linezolid in treating MRSA bacteria, though they are available, but those are the commonly used antibiotics. Our objectives were to assess the therapeutic outcome of vancomycin treatment depending on the time point of its introduction after obtaining blood culture reports. Unit-wide prevalence of MRSA teaching hospital Anuradhapura, severity and comorbidity related to MRSA bacteremia was analyzed to indicate the possible mode of transmission and resource. Ethical approval was taken from Faculty of Medicine and Allied Sciences. The sample collection carried out in teaching hospital Anuradhapura, Sri Lanka. It is an approximately around 1839 bed tertiary care medical facility with university professorial unit. The hospital serves to the population of 1.2 million in North Central Province. We analyzed the microbiology laboratory records and bedded clinical records of Staphylococcus aureus and MRSA bacteremia patient admitted to teaching hospital Anuradhapura 2012 to 13 December. All the clinical investigations have been done by consultant physicians and microbiology investigations being conducted under the direct supervision of the microbiologist. So investigation has been conducted using BACTEC 3D automated blood culture machine, and the disk diffusion test has been performed according to CLSI. So cases of culture proven Staphylococcus aureus infection with bacteremia were enrolled in this study using the information obtained from bedded tickets and laboratory records. So admission books and record room data were used to locate the unit of patient's admission. Mortality was calculated according to the post-mortem reports. So MRSA bacteremia prevalence and timing of anti-MRSA therapy. The prevalence of MRSA bacteremic rates were calculated in different units, including the intensive care units. Since vancomycin is prescribed as a main anti-MRSA treatment, timing between vancomycin susceptibility results and initiation of vancomycin therapy was calculated. So assessment of the severity and outcome following MRSA bacteremia. Severity of MRSA bacteremia was assessed using Pitt bacteremia score, and comorbidity was calculated using Charlson Comorbidity CCT index. So clinical evolution was classified as a cure when the clinical manifestations disappeared, and the clearance culture became negative and as a failure when there was persistence of the clinical manifestations, persistence of positive cultures, or evidence of death due to MRSA bacteria. Death was considered to be due to MRSA bacteremia when at least one of the following criteria was satisfied. Culture positive for MRSA from a sample obtained at the time of death, persistent septicemic symptoms or occurrence of death without any explanation within the first 7 days after the diagnosis of MRSA bacteria. Deaths that did not satisfy one of these criteria were considered to be consequence of patient's underlying disease. The follow-up period was from the diagnosis of bacteremia until the cure or death. Statistical analysis was using SAS 9.1. Demographic data were presented in measures of central tendency, while chi-square test was performed to assess the factors associated with survival and mortality following after 7 days of MRSA bacteremia. results. A total of 13,260 blood samples were investigated for possible bacteremia. Of those, 1,352 blood cultures were identified as bacterium, and presence of staphylococcus aureus bacteremia was detected in 655 samples. Out of 655, 61, only 9.3, indicated the presence of MRSA. It was further calculated that 0.28 MRSA bacteremic incidence per 1,000 admissions. The highest prevalence was observed among people who age more than 60 years. So you can see it's the age-wise distribution. So it is highest among perhaps more than 60 years, while unit-wise prevalence was highest among nephrology unit, followed with orthopedic and collectively in the ICUs. Surgical units also there. When the risk factor for acquisition of MRSA bacteremia is considered, 40%, that is 26, were with peripheral cannula. 16 were on peritoneal dialysis, while 16 were, yes, it is 26 point here, were with the urinary catheters. 4 were with AV fistulas and 6 were with, they were intubated. Furthermore, 10 were undergone previous surgeries and 5 were following chemotherapy. 10 were associated with polytrauma. With respect to comorbidities in MRSA bacteremia, the CC index was 4.8 plus or minus 1.3, and the severity of MRSA bacteremia was PIT score was 8.3 plus or minus 1.5. Fever and local signs were the most common clinical manifestations. About empiric therapy, at the time of receiving the positive results of blood cultures, 49 were on third generation cephalosporins, 5 were on fluoxetine, and another 5 were on coamoxicillin. Only 2 patients had been kept without antibiotics. After detecting MRSA in blood culture, the antibiotic administered was changed to glycopeptide in all the patients. That's the usual practice in Sri Lanka. 39 patients were changed into vancomycin within 24 hours of obtaining the results. Further, 10 patients were changed into vancomycin after 24 hours of receiving blood culture results. 7 patients were died within first week of positive blood culture reports as a consequence of septicemia. Further, 7-day mortality was significantly high among patients with vancomycin therapy compared to teicoplanin therapy. So, since mortality was high among vancomycin treated category, further analysis was done to assess the contributory factors which influence the mortality. Following on or before 24 hours of initiation of vancomycin treatment following positive blood cultures, there were 37 survivors after day 7 and only 2 died as the consequences of MRSA bacteria. Following after 24 hours in initiation of vancomycin treatment, there were 2 survivors, while 8 died as consequences of MRSA bacteria. So it's there, it's significant. That is, when the factors individually considered, initiation of vancomycin treatment following 24 hours after of blood culture positivity was significantly contributed to 7-day mortality. The severity of MRSA infection, that is PIT score, if it is less severe, less than 4, if it is termed severe, if it is more than 4. And having comorbidities using CC index was not significantly associated with 7-day mortality. 7-day mortality of MRSA bacterium is further analyzed using logistic regression of similar parameters. Those are comorbidities, severity of infection, and timely introduction of vancomycin. So high PIT score and initiation of vancomycin therapy after 24 hours of receiving blood culture report were independently affected the MRSA bacteremic patients' 7-day mortality. Having comorbidities did not show a significant impact on 7-day mortality. The interaction between 2 independently significant factors, PIT score and timely introduction of vancomycin treatment, were not significant. So, in our study, the percentage of MRSA bacteremia out of Staph aureus bacterium was 9.3. So, they are in different values, like in Europe, there in Iceland, it's almost, there are studies that was 0, like from Malta, it was 52.4 like. So then French UK already has demonstrated the decline in MRSA bacteremic rates over recent years due to implementation of multifaceted prevention programs. The highest number of MRSA bacterium was found in nephrology, and that would be due to large number of dialysis patients resulting from chronic kidney disease of unknown etiology. That is the epidemic which prevailed in the north central province of the Sri Lanka. At present also it is going on. In our study, the 7-day mortality following Staph aureus bacterium was 0, while MRSA bacterium was 13.1. So there was a study conducted in Middle East, in Saudi Arabia, at the tertiary care hospital showed 36.4 mortality in the patient with MRSA bacterium. In Southeast Asian countries, mortality rate associated with serious Staph aureus bacteremia was high as much as 50%. The relative low 7-day mortality THA would be mainly due to early detection and implementation of appropriate therapeutic options such as anti-MRSA, antimicrobials, and supportive therapy on time. The low 7-day mortality of MRSA bacterium was observed in the patients who received vancomycin therapy on or before 24 hours of blood culture antibiotic susceptibility test reports. This signifies a golden hour of initiation of vancomycin on MRSA bacteria. The delay in the introduction of vancomycin has significantly increased the mortality. So clinicians in the THS seems reluctant to prescribe vancomycin as first-line therapy to treat MRSA bacteremia because of vancomycin having a potential nephrotoxic effect. Similarly, ticotrin also has nephrotoxic effect. So, but it may be due to mainly high prevalence of chronic kidney disease in North Central province, so clinicians reluctant. In addition, having a significant delay of reaching of blood culture reports from microbiology laboratory ward settings would remarkably affected the 7-day mortality. The highest mortality was observed in patients who were vancomycin compared to ticotrin, but there were no reports in literature that allow us to contrast this effect. Further studies will be required to confirm the clinical relevance of this finding. Recent studies have shown suboptimal results in the treatment of bacteremia and endocarditis using vancomycin. So, on logistic model, the low pitch score has significantly influenced the 7-day survival of MRSA bacteremia patients. Further, chi-square test showed timely start of introduction of vancomycin treatment has significant influence on 7-day mortality following MRSA bacteria. However, the pitch score did not influence significantly. In conclusion, the start of vancomycin therapy within 24 hours of receiving blood culture report is significantly useful to reduce the mortality of MRSA bacteremic patients. So these are references, and thank you.